Welcome to Soft Bites Podcast. Your life, your dentistry. We talk about ways to have more fun and meaning in one of the coolest and most rewarding professions in medicine. Conversations on how to bring awareness, create a healthy workplace, and provide emotional insights to make dentistry a fulfilling activity while making space for one's wonder, creativity, and freedom. Here are your hosts, Manuela and George Andre.
Hi, Manuela. Hi, Antonio.
Hello everyone.
Hello. Hello,
So
everyone.
today we have a very special guest here, Professor António Mata. He's Antonio for the next 2 hours, and it's a real pleasure for us. We've been talking, me and Manuela, we've been talking about research and publications, and I and I suggested the name of, and we both remind ourselves of bringing Antonio here because to start, Antonio has an amazing CV. I mean, I'm not going to even start to name the all the items in your CV, but basically you are a PhD in a UK university. You are also a full professor in Lisbon University, right?
Right.
You are pretty much, you have a very intense academic career in terms of research. I mean, you have over 100 publications and in book chapters and stuff like that. You have above 200 communications in congresses and posters and everything. So it's really is an amazing CV, and it's really a pleasure for us to have you here. I'm sure there's a lot of things that we have that we'd like to discuss with you within the scope of evidence-based dentistry, but also I think which is quite interesting, and we are also going to touch some of those points, is that you have a lot of leadership roles. I mean, you do many different things, right? You are not that pure researcher. You also have you also do some clinical work. You are also a clinical director of a private practice. You are also on the scientific committee of the Portuguese Dental Council. I mean, there's a lot of things that you do, and I like doers. I like people that do stuff, and not only do stuff, but they do stuff from a point of goodwill. Because when I look at all the things that you have done, it's very interesting that many of those things were actually for the community and to help people around, which is very interesting. Very interesting to have you here. So thank you again for being here, and I'll let Manuela start.
Well, I'm going to start by saying welcome, Professor Mata. To me, you are always going to be Professor Mata because you were one of my first professors in the University of Metabolic Biochemistry. So, so welcome and thank you so much for being here. I want to start by asking you. To tell us a little bit more about yourself. You are one of the most respected researcher and scientist in dentistry in Portugal with proven work. So who is Professor António Mata, and what is he trying to contribute to this profession?
Well, António Mata is, of all things, is a dentist. And he sees dentistry as a very important medical field. It was not my first choice. As many others, I wanted to be a doctor. Cardiology was my intention in first place. And this story has been many times told, but I can tell it again. I come from a family of engineers, and I didn't get to get into med school at my first try. I was 17 years old, and by influence of my brother, I tried. I was placed in Instituto Superior Técnico in a course of physical engineering, which has now an accessing grade more higher than dentistry or medicine itself. But at that time it was not, so I entered the first course of physical engineering, but it was a disaster. I hated it. So my nickname at that time was the tourist in Institute Superior Technique, because I was last one to come in and I was the first one to get out every day. I didn't like it at all. And in second grade, in the second year, I decided it was too much and I didn't want it. So I went back and tried med school. I wasn't placed at med school, and I entered in the dental school. The first 3 years went fine because it was very alike the medical course, because we did the 6 years, so the first 3 years were very alike. And when I faced the last 3 years, it was a bit of a shock, because I never thought doing something so technical so that needed so much handwork, and I was not prepared. So it took a lot for me, a lot of hard work to be able to do it. So parallel, I started very early to contact with the academia, and I started very early to contact with academia, and biochemistry was my first love. So as long as I went on constructing a clinician career, because I always wanted to treat people and I wanted to be involved in community, and that human perspective of medicine or the clinical work was, of course, my objective. But I also wanted something, not only an intellectual work, but something that was related to medicine and the physiology of the human body. And so those two parallel careers started to develop. And so today I'm a clinician, but I'm a clinician who is always divided between the love for academia, the love for research, the love for teaching, and the love for treating patients. And I could never decide one over the other. So what I'm trying to contribute to, and what I think that I did for the past 3 decades, was to bring people along constructing my passion, and to try to shape and turn dentistry in I mean, 30 years ago, dentistry was very technical, and that's it. And what we have seen for the last 30 years is an amazing development at dentistry as a scientific field, gaining shoulder to shoulder with the other medical fields. And the same problems that dentistry has today are the same problems that the other medical fields have today. So the challenges that dentistry are facing these days are exactly the same that the other fields of medicine are facing. And modestly, I think that what I try to do, and what I've tried to do these last 30 years, was to contribute a little bit to place dentistry shoulder to shoulder with the other medical fields, bringing the other people along to fulfill this dream, constructing research teams, constructing clinical teams. I'm a team person. I don't like to work alone. I like to work with other people. I like to hear what other people have to say, what they have to bring aboard my projects, and so my objective is to not to build a personal legacy, but to build a group legacy for medical. For instance, our research group is celebrating this September 25 years of existence. The oral oral biology research group. And it has continuously researched for the past 25 years and published for the 25 years in the oral biology field in Portugal. So that is something that really fulfills me with joy, because when we started, the first time when I came, I did my PhD in England, and the field was a very specific physiological field. My field of my theme of the PhD was about the effect of calcium and magnesium transporters on acinar cells in the salivary glands. And the first time I came to Portugal, when I came from England, I went to present a self-reported communication in a congress in Portugal, and everybody was presenting clinical cases. The communications were clinical cases, and at the point the host of the session said, "Now we are having a different communication. It will be effects of extracellular magnesium on the transport and production of acinar fluids in salivary parotid cells of the rat." And everybody leaves the room. There was nobody. So there was me, the host, and I did a presentation virtually alone in the room. So now, when we go to a congress, we have several dozens of posters and communications in the oral biology field, in basic science, in dentistry, in Portugal and everywhere else in other countries. And so there was a very big change these past 3 decades. And I'm glad I was part of it. And so that's what I try to contribute on one side is I have tried to contribute these past years was to bring dentistry to a more scientific field. But not only, I mean, this was not enough. And well, we can talk about that later, but I always thought that there was a missing link on how basic research and research could contribute to clinical decision. So that's when I found, and we can talk about how that happened, that's how I found the evidence-based paradigm. And then when I contacted with the evidence-based paradigm, it changed my life as a person and my life as a clinician, my life as a researcher, because it was really the missing link that we have been waiting for, that would enable to complete what today we call the translational path, from the moment someone has an idea till the moment that that idea gets to the chair side of the patient. And so I have been, for the last 15 years, very involved in trying to bring the evidence-based paradigm to all the clinicians, because there's a misconception that evidence-based dentistry or evidence-based medicine is about research. It's only for researchers, while it's completely the opposite. The evidence-based paradigm is designed to permit clinicians to bring on research that they don't need to do, but they need to bring it to their clinical decisions. So that's what I'm trying to contribute for.
Yeah, and you mentioned, Antonio, that evidence-based dentistry changed you even as a person. And you already brought some light of what evidence-based dentistry is. So, in a nutshell, what is evidence-based dentistry? Why is it so important? How did it change you as a person?
British people say usually, or British doctors say, that evidence-based medicine is not medicine based on evidence. There are lots of misconceptions about what evidence-based is. People think that going to get a reference from a journal and underpin it in their presentations, or bring it to the patient and bring only one paper to their clinical decision is doing evidence-based, which is not. Evidence-based, the evidence-based paradigm is an algorithm for clinical practice. It's a very specific algorithm. In 1987, three doctors from the McMaster University, Brian Hayes, David Sackett, and Guy Wyatt, launched a statement saying that as best intentioned as they could be, clinical decision based only on authoritarian perceptions, on self-perceptions of doctors, on biological plausibility alone, which is something that happens very much, were not enough to take clinical decisions. And that clinical decisions should be based on the best synthesis, the best collections of all the evidence that exists over that theme. So that would not have been possible to do without the development of the internet. The development of the web was the first disruption in the clinical practice everywhere, because with the web came along the references bases like PubMed, like Embase, that enable someone to very quickly access to all the evidence that exists. But that launched a new challenge, that was, how can I get this information of this data transforming into knowledge that could pertain to clinical decision? And so this algorithm was developed, which is known as the 5 A's, which is ask, acquire, appraise, apply, and assess. So we ask a question from the patient, or the patient asks us a question, and still today, unfortunately, what is the most used source of information for a clinician when he has a doubt, or when the patient poses him a question? It is an older colleague, still today. And I usually say there is nothing wrong with that, as long as you don't try to call a second colleague. Because it's when you call a second colleague that diversity in what you should do starts to appear. But the first step is you having the conscience that you have a question that you need to answer. And that arises, for instance, in dentistry, about 70 times a week in a clinician, in a full-time clinician, 70 times a week, we are facing questions that we need to answer to patients and to take clinical decisions about it. So the first thing was to get a framework to design good questions in medicine. And that's where the PICO paradigm came about. So who is the patient? What is the intervention? What's the exposure that I'm considering? To what is it compared? And what is the outcome that I must search for? So learn how to frame good clinical questions is the first step. The second step is, and the framing of this question will give us the keywords for search in a search engine, to go to a database and like PubMed and start to search based on those in adult patients, doing the crown the same day of the implant when compared to a deferred crown. Would it have the same longevity or the same success, one technique over the other? So that will give us the adult patients, implant dentistry. So that will give us the keywords to construct our search. Then we are supposed to get all the evidence that we can find about it, and then we must appraise the evidence. So we must say, this is good evidence, this is not good evidence, this is good research, this is bad research. Take the good research, filter, distill it, and try to make construct a clinical decision about it, expose it to the patient, and then assess the result of that, of the technique that we have chosen it and we have applied on the patient. Of course, we thought that if we could teach this to clinicians, this thing would be automatically widespread and everybody would adhere, which was not. And it was not because we don't have the time to do it. This is a very demanding world. Time is very short. And if we have 70 questions a week, we are not able to search for this evidence. So that brought along this division that emerged between what are EBD doers and EBD users. So we found out a few years later that we needed to do, we EBD doers, the evidence-based doers, needed to do the work for the evidence-based users. And that's how what we call secondary research emerged, which are the systematic reviews, the assessments of what we call the evidence-based journals that assess papers and publications on their own and give advice to clinicians, or evidence-based guidelines. So types of publications that are syntheses of the evidence. So we do the work so today a doctor does not need to go through all this process. So he has is this position. He can, what he needs to search for is for the secondary evidence. So systematic reviews. Now, of course, the evidence per se, and this is other misconception, is that so I found the best evidence, I'm going to apply it to the patient, whether he wants it or he doesn't want it. And this is other misconception. Once I was, well, I'm speaking, but you can interrupt me because I speak a lot. If you want to change the course or do another question, you can interrupt me. That's good.
It's fine.
But once I was in this Congress and some former students of mine were presenting a clinical case, and they said, we did this in an evidence-based way. This was many years ago. And so I was interested to listen. And they did everything right. They said, we framed this question, we went for the evidence, this was the evidence, we found these articles, these were good, these were not, we evidenced this as a system, which was critical appraisal skill program. There are many systems for appraising evidence. And they say, so we found this was the best technique and we apply it to the patient. And I thought, no, now you did wrong. Because the evidence-based paradigm is this algorithm that I have described. But then when we have the evidence, there are other two circles that you have to intersection with, which is patient expectations and the expertise of the clinician. And this has to be, so evidence per se is never enough. And this is a misconception that sometimes older colleagues try to say, no, but I don't want to be a slave of evidence because I have my own convictions, I have my own feelings, I have my own way about making diagnoses, about choosing, and so this, I don't want to be a slave of the evidence. And they are missing the point because they are not meant to be. The evidence-based dentistry paradigm has this algorithm to find the evidence, but then when you have the best evidence about this question, you have to discuss it with the patient. So we need to integrate it with patient's expectations, and then you have to integrate it with your own expertise and your own experience. For instance, if you say, well, this is the best technique, and the patient say, well, let's go for it. You must say, no, but I don't do this technique. I do this, and this technique has less % chance of getting success. But the patient says, no, but I want to go for it anyway because I want to do it with you. But at the end of the day, if you have applied this paradigm, you will have A patient is informed with the best trustworthy evidence, and that is making a conscientious choice about the treatment that he wants to go and who he wants to go with through this treatment. And this is very important, and because this paradigm has completely redefined the way of doing modern medicine. Every aspect of modern medicine owes it to the evidence-based paradigm. The search that we today do for health quality, best practice in healthcare, patient-centered outcomes, all these fields which are very important nowadays, the quality and the utility of the evidence and the research that we do worldwide, all these questions and all these problems and all these different ways of producing clinical decisions nowadays owe it to the evidence-based paradigm. So it is not possible today to practice modern medicine without having a notion about what the evidence-based paradigm is.
I was going to continue because I think the question that we have here next comes on the following, because you mentioned all the variables there are in the evidence-based dentistry. So for the daily dentistry, for different patients, we need different treatments for the same problem. We may need to adapt also due to limitations, time, materials, patient motivation, patient expectation, like you said. Colleagues and dentists don't need to feel inferior for sometimes not being able to do the ideal practices, because there are a lot of variables here, and sometimes you are not able to follow all the protocols and all the evidence-based dentistry. Does this make sense? And if so, when is legitimate to do so?
No, it makes it makes much sense, because first we have to define what is a good practice. Good practice is a very relative concept, because what can be a good practice for a patient can be not for one, and there are several ways to achieve the same goal and the same clinical goal, which is to give a better quality of life to your patient. At the end of the day, that's what medicine is about. You have to give a better quality of life to your patient. Even this aspect of being concerned about the patient's quality.
Sorry, António, just let me interrupt? You said at the end of the day, the goal is to provide a good quality of life to the patient. Tell me if this makes sense. To provide the good quality of life to the patient while he's still alive. Does it make sense?
Of course, and
because, for example, a treatment for an 80-year-old for the same problem might not be the treatment for the more or less the more anatomical or dental problem for someone that is 20s, right?
Of course.
Does it make, or is it a very cold point of view of things?
No. For instance, when you consider for full arch immediate load in implant dentistry, age is a major factor.
Sorry. I was exactly thinking about that. Because that's actually one of the cases that I think that sometimes people forget, that the age of the patient and the trauma of the patient is they don't bring it into the equation. But sorry to interrupt you. Yeah, but that's an amazing example.
Yes, because it's very different to do it if you're 50 or if you're 80. And you have to consider and inform the patient of the and once again, one thing that at 80 years old can really improve your quality of life can impair it when you're 50. So clinical decisions are very different on different patients, and but also what you were asking, Manuela, is do we have is it legit to have different solutions for the same patient, and if these solutions are driven by the conditions of our own clinical practice. I mean, not only our expertise, as we were saying, but sometimes our clinical practice. Clinical practices and clinical settings are very different, as we know. And one of the things that the evidence-based dentistry also looks upon, it's the external validity of the clinical research. One thing that I would like to say is for clinical research and for clinical decision, the only research that interests us as clinicians is clinical research, is research performed in humans. So this is also something that we see, and in dentistry it happens a lot. For instance, in restorative dentistry, most of the clinical decisions still today are based on evidence that is done on in vitro studies, dentin discs, enamel discs. And that is not something that is very important for clinical decision, which is external validity. When you appraise a paper, a clinical paper, every appraisal sheet, every appraisal system, with maybe Joanna Briggs or maybe the critical appraisal skills program or the assessment of bias from the Cochrane system, all the systems do the same, different questions, but on the same topics. And there are 3 topics that you want to know about when you are assessing a clinical paper, which is what we call internal validity. First is, are the results of this study true and not biased on the people or the patients that have been used on this study? That is the first thing that you want to know, because if it is not, the paper is rubbish. Then you want to know, are the clinical findings important enough? What is the dimension of the effect that comparing these two techniques are found in this paper? Is it a clinical effect that is meaningful? Is it big enough? Or is just statistical rubbish, as we say? And then the third thing, which is very important, is the external validity, which is what are the characteristics of the patients to whom these results can be applied. And this varies a lot from setting to setting. It is very different to see private patients and have the time you want for seeing that patient than working on a clinic that works with insurances and that you are forced to see patients every 30 minutes. This is very different, but still you can perform a good job on both settings. So clinical decisions are very different from setting to setting. The clinical decision that you need to take varies a lot from setting to setting. And this is another big importance of the evidence-based paradigm. There is nothing more difficult than to change your clinical practice. This is proven. It is very difficult to change your clinical practice. Lots of things have to happen. And it starts with the people that own the setting in which you work. Is it you? What you want to do about it? Or are it others? And do you feel every day what we call external factors of pressure in the clinical decision? When an insurance pays 30 euros for an extraction and 30 euros for an endodontic treatment, they are pressuring your clinical decision. And so the evidence paradigm here once again can help you to explain the patient the differences that exist between taking one decision over the other. And at the end of the day, it's a decision in which the patient has to be involved, but you have enlightened him to take what he thinks and what you think are, if not the best decision of the world, the best decision that can be applied in that setting.
So Antonio, it's like evidence-based dentistry will never leave you alone or isolated, no matter the conditions that you work, right? So there's always something that. So it's basically what's the best thing that you can do at this point in time with this given patient at the conditions that you have at this point, right?
It's very difficult and it's very variable, and you need this tool to take this task of doing medicine. And clinical decision is the most difficult task and the most difficult job in the world. We can talk about it a bit later. That's why IA, for instance, or AI, as we say in English, artificial intelligence, has taken so long to, or is so underdeveloped in the medical field when compared to other fields. It's because practicing medicine is the most difficult job because it's completely uncertain. It's uncertain all along the clinical path. It's uncertain on the diagnostic procedure. If the Diabetology Society comes today and say, well, we now think that we should diagnose his diabetes at 90 of glycemia instead of 120 in the fasting state, you will instantly have millions of more diabetic people in the world. So diagnosis is a very uncertain thing. Is there a care? Is just an image? Can this tooth be saved? Can it not? Then choosing the treatment and discussing it with the patient is very uncertain. Which is the best treatment option? Then, when you have decided what you think is the best treatment option, you apply it to the patient. And applying it is very uncertain because sometimes you say, I'm going to take this little root off and it's going to be easy, and it becomes a nightmare. And some days you have cases that you think this is very difficult to do and everything goes along very finely. So it's very uncertain. The result is completely uncertain. You did everything good in an aesthetic rehabilitation. The patient goes to the mirror, he sees himself, and he tells you, I don't like it. So, and this is very disturbing for everyone. Principal or mainly stakeholders, we have to put the money in these things. Nobody wants to invest in a field that is so uncertain. So this is to say that this uncertainty is something that we cannot escape for. So the best we can do is try to find the best decision for that patient in that moment and try to apply it. And that varies a lot with the setting you are in, the patient you have facing you. And evidence-based helps you. That was a very good sentence, George. It never leaves you alone. I'm going to steal that one. It's a very good concept because that's it. You are not alone anymore.
Yeah, because I was the thing I'm trying to place myself in the feet of a young dentist who's maybe just he has some lack of confidence, and he reads some papers, he tries to do his best, but then he's faced with a situation that he believes he doesn't have the best materials or the options to treat the patient in what he believes is the best way. So in a more direct way, what should that young dentist do at this point in time? So basically, is it legitimate that he informs the patient that, look, the best treatment possible is this one, but I will not be able to do it today? Is it a legitimate thing to do so? I mean, because that brings a lot of other issues, which is like, how am I going to talk to the clinical director that hired me? You know, it brings so many. So what I know you don't have an easy answer for that, and especially if you bring also insurances. But and of course, at a limit, you also may eventually think about leaving that practice. That also is something that you need to be on the table, right? But it's for a young dentist that is faced with a difficult situation that it doesn't have the means or the materials to do something. What do you think it is the best advice if he still wants, if some treatment needs to be done at that point?
Well, that's a
Tricky
very
question.
tricky question.
Tricky question.
That's a very tricky question. But first, before going into that, I would like to say, well, I'm not against stakeholders or against insurance. I'm against insurances that do not seek to get the best efficacy or effectiveness of the treatments they can provide, which is a different concept. For instance, and evidence, I'm saying this because the evidence paradigm also helps stakeholders. It's not the enemy of the stakeholders or the insurances. For instance, in the UK, many years ago, 10 years ago, everybody in the UK which works for the NHS would always extract wisdom teeth in all patients, always, because that was paid. And so the NHS commanded the Scottish Intercollegiate Network, which is an organization that provides evidence-based guidelines. They construct evidence-based guidelines upon demanding. They have commissioned them to do an evidence-based guideline on when should really wisdom teeth be taken off and extracted. And they have defined the indications and contraindications for extracting wisdom teeth. And that saved a lot of money from taxpayers. And that was a very good thing to do. So that's a good example on how evidence-based dentistry can also help to rationalize community services. Not everything has to be bad, but I think that in Portugal, we live a particular moment which has been going on for too long on insurances and having a wrong focus, because maybe they are not also used to rationalize treatments and look at evidence-based dentistry as a mean to save more money where it has to be saved instead of spending it and putting all the burden on the dentists. So that's also a message that I would like to leave, because the evidence-based paradigm can be very useful for stakeholders and to spend money where it should be spent and to save money where it should be saved. That being said, I think it's very difficult for a dentist in that situation to take a good decision. But what he has to do, and the point here is always the same, is patients need to be informed with the right evidence. So this is about the motto for the Cochrane is better evidence, trusted choices. That's their motto, and that's what it is about. Is choices must be made based on the knowledge of the evidence. So if the patient is informed, the patient will know what to do, more than the clinician tries to drive him in one way or the other. The role of the clinician is always to inform the patients on the advantages and disadvantages of certain technique over the other technique. And then the patient has to decide. And he has to decide many times with his own, for instance, financial constraints that he has. because, and if we look at the Portuguese reality, you don't even have a good system of healthcare, of dentistry in the public service, or in the primary care. So a lot is being doing, we are progressing, but we are still very far from other countries in concerning that topic. So information is the key word here, I think. And I think that sometimes it misses a lot. Patients are not informed. What we see in those kinds of settings is that, patients are not informed. Look, I'm going to do this way. These are the limitations. It could be done the other way, but we don't have the time, or you don't have the money, or you don't have. But you must know that there are these options, and that these options will have this longevity, this probability of success, and the decision we are taking together. It's a decision that you are taking, being informed. You have to inform patients.
George Andrés just made you a question about a young dentist, and you already also talked about the importance of professional experience. So how does professional experience really influence the evidence-based dentistry, and how important it is experience in dentistry?
Experience is very important in medicine. That's another misconception, that very often older colleagues which are defiant about evidence-based, they mistrust the evidence-based paradigm because they think that once again the evidence is here and the burden of evidence is there to completely obliterate their experience, to make no sense of its experience. And that's not the case. Experience is very important. It has been proven that experience drives you to the right diagnostic much more rapidly. So you learn over time. Plus, we know, and we don't put aside, we evidence-based champions do not put aside the utility or the usefulness of the experience. Experience is very important. Experienced doctors have a certain type of flair. You don't explain this scientifically, but we know it happens. They have they have a certain type of flair to get to the diagnosis and to choosing the best treatment much more rapidly than a young clinician. The difference is
sorry to interrupt you. Is it confidence, that flair? It's based on confidence, you think? Or it's
we
not,
don't
has
know
nothing
on
to do
what
with
is
that?
based.
I think it's magic.
It has something to do with something that we cannot measure. But what has also been proved, that there is a declining slope of knowledge. So if you pick an experienced doctor and you put him to do the faculty exams, he will fail much more than a young student. So as time passes, there is a clinical slope, what we call the clinical descending slope of knowledge. So as you get more experience, you also lose part of your knowledge. And that's where the evidence-based paradigm helps you. It's to keep track of the knowledge that you should not have left behind. So if you don't do nothing and just trust your experience, you will not take the best decisions. So you need to integrate. That's why you need to integrate your experience with the current knowledge and with the patient's expectations. We must never forget.
Yeah, I think it's very interesting what you're saying, and because I'm 45 and I'm starting to feel that already. You know, I'm starting. Yes, I am more experienced. My ego in the clinical field is bigger, which is a big trap, right? But also, I it's more difficult for me to keep up with knowledge. That's what I feel. Maybe just getting older, but I completely feel what you're saying. So I think that's very interesting.
And do you think that when you get older, sorry to just out of curiosity, when that happens, because I think that we are all aware of that, what you just said, Andrea, but do you think that there's no curiosity of keep on looking and keep on learning? So you are confident on, you already have some experience, you are confident on your work, and it's like, okay, now I'm good. Or it depends
I,
on
th-
your
I
personality.
think, I mean, I'm very connected with education and stuff, but even still, I have to admit that I was more. I think I was. I don't know if it's up to date is the best word, but I find it more difficult to be up to date now than when I was 30. And I think that part of that has to do with my ego.